I just want to spend 12 minutes approximately discussing the use of gonadal shielding and how this has changed with time and how we may need to reconsider our use of gonadal shielding. This talk is based on a talk by Melissa Martin, which she gave at CDPH approximately 1 year ago. And I use QR codes to help guide you if you want to select any of the reference articles. So to start with, is gonadal shielding really a best practice? What is the effectiveness of gonadal shielding? What has been the impact of automatic exposure control and the use of gonadal shielding? How has perceived organ radiosensitivity changed with time? What are the psychological benefits of gonadal shielding? And what are the next steps that we should be taking? So from a historical perspective, radiation doses from diagnostic X-ray examinations are now approximately 20 to 25 times less than they were in 1950. For example, for an adult KUB in 1950, radiation dose was approximately 11 to 12 milligrays, whereas now this is down to 0.5 milligrays. And for a newborn KUB in the 1950s, this would be 1.4 milligrays, whereas now 0.07 milligrays. So clearly we've made enormous advances in radiation safety in the last 70 years. Also from a historical perspective, gonadal shielding reduces gonadal doses to less than 10% of the original dose, was what was recorded in many articles back in the 1950s. But this best information in the 1950s was in error. Also from a historical and also current perspective, the failure to perform gonadal shielding results in severe disciplinary action against technologists. This is still very real today. The current California state regulation Title 17 states, gonadal shielding of not less than 0.5 millimeter lead equivalent shall be used for patients who have not passed the reproductive age during radiologic procedures in which the gonads are in a direct beam, except for cases in which this would interfere with diagnostic procedure. Two recent papers have disputed this, and these include reconsidering the value of gonadal shielding during abdominal/pelvic radiography and patient shielding in diagnostic imaging, discontinuing a legacy practice. How effective are accurately placed gonadal shields? Let's first look at the male. So flat lead shield, reduced dose to the region of testes of an adult anthropomorphic phantom by 36%. This was thought to be a reasonable measurement of performance of a flat shield, but much poorer performance than the claims from the 1950s. The simplistic model for males would assume 1/32 or 1/16 inch of lead, which would decrease the primary beam by more than 90%. It also assumes the location of the testes are centered bilaterally and close together, near the surface, close to the shield, which is not always the case. This would be that situation where they're near the surface, close to the shield. But as you can see from this MRI sagittal plane, they can be at a various depth beneath the surface shielding. And that they will also be within the protected region below the shield, which is not always the case. In the top example, they would be. In the bottom example, they would not be.
All right, welcome to Dr. Quinn's neighborhood. Shout out to Mr. Rogers. I'm going to go over dosimeter badge and also what kind of lead you need to wear on your abdomen and pelvis for specifically radiation protection. I'm going to talk a little bit about the two-piece, which is what I prefer. There's solo pieces are basically front aprons, which most interventionalists and people that are doing a lot of procedures do not wear, mostly because it doesn't provide protection in the back. So I'm going to show you first our two-piece, which usually consists of a skirt, which is this. Usually has a little bit of lumbar support, which I also prefer too. Go ahead and put that, wrap it around. It's usually here. It provides a protection from both the front and the back. So you can see that you actually have posterior protection. The other thing that is preferred is the upper garment of the two-piece. You can either have a rear entry like I have here. I also notice that I have 2 arm sleeves, which I prefer to help prevent radiation exposure to the armpit. There's been described an increased risk of breast cancer to radiation technologists over some studies in the past from about 1994 to 2008. They've followed a whole group. So this is what I prefer in order to do. I also have my thyroid shield, which is usually hanging from my 2-piece, particularly the upper body 2-piece. Go ahead and do that here and here. Go ahead and put the thyroid on, and then there you go, you're protected. So that's the 2-piece, and this is what's usually preferred for most interventionalists.